Dear trainees, welcome and thank you for being here today. I'm Navneet Singh, your host for this webinar. I know that today's topic might bring up a number of questions from you. So you may type your questions in chat box and I want to let you know that we will address as many as we can in the time we have today. And I welcome and request to present today's topic, Dr. Priti Lal. I request Dr. Priti to start this session. Thank you and over to you, ma'am.
A very good evening to all. At the outset, I would like to introduce myself. I am Dr. Priti Lal. I'm a professor in ENT at Atal Bihari Vajpayee Institute of Medical Sciences and Dr. RML Hospital, New Delhi. This is the institute where I work. And today we are going to discuss the third window syndrome, which I think is a very important topic for all of you from the point of view that it is often asked in the theory exam as well as in the Viva exam. You may face various questions which are related to this topic. Now, before we begin with the third window syndrome, it is important to understand the anatomical aspects which are associated with this. Now, as you all know, the inner ear with its endolymphatic and perilymphatic spaces is completely encased in a bony, rigid capsule which is totally incompressible, except at two sides. That is the two windows which are mobile, the oval and the round windows, the movement of which helps in sound perception. These are the only two mobile windows in an otherwise totally rigid bony capsule. Now, there are some non-functional openings, however, in this bony otic capsule, namely the cochlear aqueduct, the vestibular aqueduct, and various neurovascular foramen. The cochlear aqueduct runs from the scala tympani of the basal turn of the cochlea near the round window, connecting the perilymphatic space with the subarachnoid space of the posterior cranial fossa and carries with it a fibrotic periotic duct. The vestibular aqueduct runs from the medial end of the vestibule and goes to the posterior cranial fossa, carrying with it the endolymphatic duct and ends in the endolymphatic sac. Now, why I say these are non-functional is that under normal circumstances, these are narrow and long pathways, which become high impedance pathways for transmission of sound and therefore do not contribute towards sound transmission in the cochlea. This is under normal circumstances. However, if there occurs enlargement of these pathways or there are any dehiscences in the bony otic capsule, we get what is known as a third window. So third window is seen in various conditions like dehiscences over the semicircular canals, including all the three semicircular canals, enlarged vestibular aqueduct, or if there's a dehiscence between the internal auditory canal and the cochlea or the vestibule, dehiscences between the carotid canal and the scala vestibuli, or a generalized dehiscence in the temporal bone, as in conditions like Paget's disease of the temporal. So today we are going to focus on the more common third window conditions, that is the dehiscences over the semicircular canals and the enlarged vestibular aqueduct. So beginning with the superior semicircular canal dehiscence, this condition was first described by Lloyd Minor in 1998. Carey et al. had done a study on the temporal bones of asymptomatic individuals and found that 0.7% of these temporal bones exhibited a superior semicircular canal dehiscence. And Krombach et al., in his study on the HRCT temporal bones of patients who had reported with unrelated symptoms, found that 9% of them showed a superior semicircular canal dehiscence. Now, why does this dehiscence occur? The etiology could be congenital or it could be acquired. So there are two schools of thought. The proponents of the congenital theory say that as there's a high incidence in the first decade of life, it is usually bilateral, and there's a high incidence in conditions like Usher syndrome, it's most likely of a developmental etiology. Now, to understand this, we have to understand the development of the semicircular canals, which develop from the autocyst. The budding happens from the autocyst, and the first to develop is the superior semicircular canal, followed by the posterior and the lateral. Now, when this membranous labyrinth attains adult size, that is when ossification of the labyrinth begins. The ossification happens from inside to outwards, and the completely formed bony otic capsule is formed of three layers: an inner and an outer periosteal layer, and there is a middle endochondral layer. So when the child is just born or in early infancy, it is only the inner periosteal layer which exists in the otic capsule. As the child grows, the outer and the middle layers also develop. Now, any arrest in this ossification process would lead to a dehiscence or a thinned out covering of the superior semicircular canal. The acquired causes which could lead to a dehiscence could be conditions like intracranial hypertension. Then, as age advances, it has been seen that the bone overlying these canals may thin out, or in cases of head injury. So it is generally now believed that possibly a combination of both developmental and acquired causes lead to the development of this dehiscence. There is a pre-existing thinned out covering over the superior semicircular canal, which is vulnerable to these to break down as a result of various acquired causes. So coming to the clinical features of cases of superior semicircular canal dehiscence, the patient is usually middle-aged, and they may present with various audiological, vestibular, or a combination of these symptoms. So it is not clear as to why a particular patient will present with a particular subset of clinical features. A study conducted by Farmater et al. Found that the larger dehiscences, by large, I mean dehiscences which are more than 2.5 mm, they presented predominantly with a combination of audiological and vestibular symptoms. Whereas the smaller dehiscences, they tend to present with either the vestibular symptoms or the audiological symptoms. Now, one of the predominant symptom is hearing loss, which is conductive in nature. Now, this conductive hearing loss in a setting of an intact normal TM is aptly termed as inner ear conductive hearing loss, where we see worsened AC thresholds and improved BC thresholds. Sometimes the BC thresholds are better than even 0 decibels, resulting in an airborne gap, which is largely in the lower frequencies. Now, why do we get worsening of the AC thresholds and improvement in the PC thresholds? To understand this, let us first see what happens under normal circumstances, is what is depicted by the schematic picture. Now, under normal circumstances, when sound waves strike the oval window and they push the oval window inwards, that is accompanied by an equal and outward movement of the round window. And this motion of the fluid inside the inner ear leads to vibration of the basilar membrane and hence a perception of sound. Now what happens is, under normal circumstances, these sound acoustic energy, it cannot go towards the superior semicircular canal because that is a high impedance path. In the presence of a dehiscence, however, this becomes a low impedance pathway. And when sound waves strike the oval window, a part of it gets dissipated through the semicircular canals into the cranial cavity. And this dissipation of energy away from the cochlea leads to a decrease or a worsening of the air conduction thresholds. Now, why does the bone conduction improve? Now, when the sound energy, it strikes the bony otic capsule, these vibrations are transmitted into the fluids of the inner ear. And because of the difference in the impedance of the oval and the round windows, there exists a difference in the pressure across the scala vestibuli and the scala tympani. And this pressure differential causes the membrane to vibrate and produces a sound perceptor. In the presence of a superior semicircular canal dehiscence, as I said earlier, a part of this acoustic energy will get dissipated through the canal. This further enhances the pressure differential between the scala vestibuli and the scala tympani, and which leads to an improved cochlear response to conduction. The improved bone conduction manifests as bone conduction hyperacusis, and the patient presents with autophony, where the patient can hear in his or her own internal sounds. And sometimes the manifestation is as bizarre as the patient telling us that he can hear his eyeballs move within the sockets, or he can hear his knee joints, the knee joints move when he is walking. The patient may present with pulsatile tinnitus due to dural pulsations, or there may be vertigo, which is induced by sound or pressure. Why does that happen? So this can be understood by this schematic diagram. So whenever there is a positive pressure in the external auditory canal, or when sound waves strike the oval window, these sound waves, which earlier could not go towards the semicircular canals because of they being high impedance pathways, now gets dissipated or moves into the semicircular canal and causes a ampulofugal flow of the endolem. This ampulofugal flow of endolem is excitatory in nature, and that causes a stimulation and a sensation of vertigo. So when we do tuning fork tests in these cases, we get a characteristic features which are suggested of conductive hearing loss. Now, the interesting part here is that normally when we do Weber's test, we place the tuning fork on the vertex or on the forehead or on the incisor teeth, and the patient hears the sound. In cases of superior canal dehiscence, if the tuning fork is placed on distant bony prominences also, like the lateral malleolus of the ankle the patient is able to hear the sound in his ears. And this has been termed by some as the ankle web. Then, in response to sound or pressure, we may be able to elicit the nystagmus, which is usually in the plane of the affected canal. Pure tone audiogram in such cases reveals a conductive hearing loss, especially in the lower frequencies, as we had explained earlier. Then acoustic reflexes done show the presence of an acoustic reflex. This is very important because now this is a setting of a conductive hearing loss with an intact TA. A very important differential diagnosis in such a setting is a condition like autosclerosis. Now, in autosclerosis, we have conductive hearing loss, but the acoustic reflexes are absent. While in semicircular canal dehiscence, there will be a conductive hearing loss with an intact PM, but the acoustic reflexes are present. So in each case of where we get a conductive hearing loss and the tympanic membrane and the middle ear appears all right, we should do an acoustic reflex test before we take up the patient for surgery in order to avoid any surprises. Then the vestibular evoked myogenic potential, or the VEMS, they are also help us in diagnosing these dehiscences. Now, under normal circumstances, when a patient is exposed to a 500 Hertz tone burst stimuli, the myogenic potentials are generated because of stimulation of the ventricle and the saccule. Now, normally what we get is a positive wave at 15 milliseconds and a negative wave at 25 milliseconds. Now, in case of third window, now because of decreased impedance of the inner ear, there is greater transmission of sound energy to the ventricle and the saccule, and that leads to generation of these waves at a much lower threshold and with elevated amplitudes. So, VEMS in cases of both ocular and cervical VEMS, in cases of superior canal dehiscence, have lower than normal thresholds and elevated amplitudes. Presence of these lower VEMS thresholds in a setting of conductive hearing losses is a pointer towards superior semicircular canal dehiscence. ECOG-G may also be done. ECOG-G shows an elevation of the SP-AP ratio. Now, SP, or the summating potential, arises from the vestibular otolithic organs, and this increases in a canal dehiscence, whereas the action potential is generated from the cochlear responses, which is decreased, and therefore there is an elevation of the SP-AP ratio. The gold standard investigation in such cases is the HRCT of the temporal bones. This is a coronal section of the HRCT of the temporal bone, and here we can see a dehiscence of the superior semicircular canal on the left side. I hope you can all appreciate this dehiscence here. In another film, we see dehiscence of the canal on the HRCT of the temple. But in these HRCTs, sometimes when the bone is thinned out, or in children where the overlying bone is not completely ossified, we may get a false positive result. That is, we may get a dehiscence when there is actually none. Or in cases with patients who present with symptoms of superior canal dehiscence, there may not be an obvious dehiscence when there are some microfractures present in the overlying bone. So there may be false negatives too. So to improve the sensitivity and specificity of the HRCT, we can reformat these images in various planes, views, which are like commonly the partial view and the Stenberg's view. The partial view is a plane which is parallel to the superior semicircular canal, and the Stenberg's view is perpendicular to the superior semicircular canal. Then we may also decrease the collimation thickness to about 0.5 mm, and that would increase the pickup rate of these dehiscences. The MRI actually does not play much of a role in the primary evaluation, but in post-op cases, we may use it to see the effectiveness of canal plugging procedures. Now, how do we treat these cases of semicircular canal dehiscences? Now, for patients who are asymptomatic or are mildly symptomatic, we need to just counsel them, allay their anxiety and fears, and keep them under observation with the advice of avoiding any triggers which cause vertigo. It is for patients with debilitating vertigo that we advise surgical repair. Surgery could involve resurfacing of the canal dehiscence or recapping or plugging. Now, in resurfacing of the canal, we cover the dehiscence with fascia, cartilage, bone pad, or bone. Now, and thereby seal this defect and seal the semicircular canal from the cranial cavity. This is a more physiological procedure because the integrity of the canal is maintained. However, it is associated with a higher recurrence rate because there is a higher chance of graft resorption. Now, to prevent the recurrence, we can recap the already resurfaced canal with hydroxyapatite. Or we may plug these canals with bone dust and or fascia and obliterate them. Whatever procedure we use, we can adopt two approaches to do these procedures, either via the middle cranial fossa approach or the transmastoid approach. Both these approaches, the choice of the approach would depend upon the location of the dehiscence and on the surgical expertise of the surgeon. Supposing there is a dehiscence on the arcuate eminence of the superior canal, that can be sealed by the easily approached by the middle cranial fossa approach. Now, in whatever be the surgery adopted, there will be resolution of symptoms in 75 to 100% of the cases, with better results being seen with symptoms like autophony, tinnitus, and vertigo. Now, when we are subjecting these patients to surgery, there is always a risk of complications which are associated with the approach or with the procedure. Now, it's like, for instance, when we are plugging or we are sealing these canals with by using the middle cranial fossa approach, we would need to retract the temporal bone, and hence the patient is can have complications like seizures, dural tears, CSF leaks, etc. Complications of procedure like canal plugging are like the patient may have a vestibular hypofunction or may also develop a mild sensory neural hearing loss. Recently, there have been procedures adopted like round window occlusion procedures, which are minimally invasive, where we just plug the round window with fascia, perichondrium, fat, or muscle, basically to increase the impedance of the round window and make the ear less sensitive to the sound and pressure stimuli. It's a very short procedure, quicker recovery. There are no adverse effects of an intracranial procedure, but the results are very variable. So that was about superior canal dehiscence. Coming to the posterior canal dehiscence, the prevalence of this is much lesser than that of superior semicircular canal dehiscence. This is most commonly seen in the posterior limb of the canal facing the posterior cranial fossa and is usually seen in association with the high jugular pulse. Most of the patients are asymptomatic, and that is probably the reason, that could be the reason why there is underreporting of these cases vis-a-vis superior canal dehiscence patients. Some may, however, present with symptoms like vertigo, autophony, pulsatile tinnitus, or hearing loss. When we do a pure tone audiometry for these patients, again, we get a conductive hearing loss, acoustic reflexes are present, and both cervical and ocular NBEMS show lower thresholds and higher amplitudes. The HRCT again helps us in clinching the diagnosis. For instance, in these figures, we are seeing, these are figures which are showing dehiscence of the posterior semicircular canal. This figure also, I hope you are able to appreciate, there is dehiscence of the posterior semicircular canal here. It's a little faded, but that is what it is here that I could get. And there is a associated high riding jugular pulse. Treatment is again similar to the superior canal dehiscence, involving resurfacing, recapping, or plugging the posterior canal with decompression of the jugular bulb. The lateral canal fistula. Lateral semicircular canal fistula is a condition which we as otolaryngologists very commonly encounter in cases of chronic otitis media, which is associated with cholesteatoma or granulations. It has been estimated that the incidence is about 2.4 to 16% in cases of chronic otitis media with cholesteatoma and granulations. And the most common site of this is the dome of the lateral semicircular canal. Why do we see this fistula or dehiscence in the lateral semicircular canal in cases of cholesteatoma or granulations? It is because of the cholesteatoma matrix. It promotes resorption osteitis due to increased osteoclastic activity. The cholesteatoma also creates a pressure effect on the bone, and there are various osteolytic enzymes produced by the cholesteatoma matrix like collagenases, cathepsin, which promote osteolysis of this bone, and we get a fistula. There are other causes also of this fistula, like a trauma, which could be even iatrogenic neoplasms or chronic infections, but we are focusing today on the lateral semicircular canal fistulas due to chronic otitis media. About 60 to 65% of these patients will present with vertigo. And in about 50% of the cases of lateral semicircular canal fistula, we would be able to elicit a positive fistula test. In another 50%, there may be a fistula present, but we may not be able to elicit a fistula, positive fistula sign. That is, we get a false negative fistula sign, which could be because of the presence of a cholesteatoma matrix in between, which prevents the transmission of pressure from the external auditory canal to the fistula. Then these patients may present with hearing loss, which may be conductive because of the third window effect, or there may be an added component of sensory neural hearing loss, giving a picture of a mixed hearing loss. The high-resolution computed tomogram of the temporal bones is very useful in diagnosing these fistulas preoperatively with a sensitivity of 85 to 100%. The only problem is that the CT cannot differentiate between an intact endosteum or a breached endosteum. Now, this is a axial section of the HRCT of a temporal bone where we are seeing a fistula of the left lateral semicircular canal. I hope you can all appreciate this fistula here. There are various classification systems to classify these fistula, but a very easy and a commonly used one is the SANA's classification, where we classify these fistulas on the basis of the size as determined from the HRCT temporal bones. So a fistula of the size of 0.5 to 1 mm is classified as a small sized fistula. A medium-sized fistula is of the size of 1 to 2 mm, and a large-sized fistula is more than 2 mm in size. There are other classification systems also, which are based on the involvement of the endosteum and the membranous labyrinthine space, but that is not very commonly used. The MRI really does not have much of a role, except that it tells us the integrity of the membranous labyrinth, but it is the CT scan which is the workhorse. Now, the management of a lateral semicircular canal fistula is essentially surgical, where we close the fistula with a temporalis fascia with fibrin glue or bone patting. Now, what I wish to discuss here is that the main issue, which is a topic of debate here, is whether when we are removing the cholesteatoma sac in such cases, whether to remove or not to remove the complete matrix. The underlying concern being preservation of the cochlear function. The advantage of completely removing the matrix is that we are removing the potential nidus of infection and also a source of continued bone resorption. The disadvantage is that if we are removing the matrix totally, we are opening up the labyrinth and we are making it more vulnerable to hearing damage. There is always that potential that we may damage the hearing. In a study by Copeland and Buckman on the management of labyrinthine fistula and chronic ear surgery, they did a review of literature and they found that actually the hearing preservation rate in the two groups, that is in the group which removed the matrix completely and the group which did not remove which left the matrix behind, there was not much of a difference in the hearing preservation rate, not a statistically significant difference. But then all those cases where the matrix was left behind had tended to have larger fistulas, and the cases where the matrix was completely removed were the ones where the fistula size was small. They recommended that generally in cases of large fistulas, that is fistulas which are more than 2 millimeters in size, and fistulas where the matrix is adherent to the membranous labyrinth, there we could consider leaving behind a part of the matrix and exteriorizing the cavity. In the rest, we could remove the matrix totally. Now, coming to the enlarged vestibular aqueduct. As I had mentioned earlier, the vestibular aqueduct runs from the medial surface of the vestibule to the posterior surface of the petrous temporal bone and carries with it the endolymphatic duct. This condition was first described by Mondini in 1791, and it is the most common inner ear malformation associated with early onset sensory neural hearing loss, with a female preponderance, and it has been seen that usually the aqueducts are enlarged bilaterally. The patient presents with fluctuating or progressive sensory neural or mixed hearing loss, which may be mild to profound, and the age of presentation may be anywhere from early childhood to adolescence. They may also have some amount of vertigo or disequilibrium. The causes for hearing loss in this could be that the widened aqueduct itself acts as a third window, leading to a conductive component of the hearing loss. Also, a widened aqueduct facilitates a greater transmission of intracranial pressure changes, causing damage to the hair cells of the cochlea. Schucknet, along with Levinson and Okamoto, theorized that the endolymphatic sac fluid is hyperosmolar, and this tends to reflux easily through a widened duct system and damaging the inner ear and causing a sensory neural hearing loss. Diagnose these enlarged vestibular aqueducts. The diagnosis is essentially made with high-resolution computed tomograms. Now, in this picture, this is a high-resolution computed tomogram of the petrous temporal, which is showing the normal vestibular aqueduct, which lies in a plane just parallel to the posterior semicircular canal at the level of the internal auditory canal. See, I hope you can appreciate the vestibular aqueduct here. However, here, if we see, the vestibular aqueduct is enlarged. In this CT image 2, we see a widened vestibular aqueduct. Now, what is a widened vestibular aqueduct? Various criteria have been given for this, but the most widely used one is that which has been proposed by Valvasori and Clemens, who said that an aqueduct which measures more than 1.5 millimeters in diameter at its midpoint on the HRCT is said to be a widened vestibular aqueduct. Jackler said that a diameter of more than 2 millimeters at the midpoint qualifies for the vestibular aqueduct to be called as an enlarged vestibular aqueduct. While Wilson said that a diameter at midpoint, twice the width of the posterior semicircular canal, would make it qualify for an enlarged vestibular aqueduct. But it is the Valvasori and Clemens criteria which is widely used. Now, how do we treat these cases of enlarged vestibular aqueduct? The mainstay of treatment is early auditory amplification. And in those cases where there is profound hearing loss, then we need to implant these patients with cochlear implants. So thank you to all of you for a very patient listening. And I would also like to thank Dr. Isha Priti, Professor in ENT at Vardhaman Mahavir Medical College, for her valuable inputs, and Dr. Ashwin Bhasarkar, a resident in ENT at NBEMS, who was kind enough to make those schematic diagrams to explain the various pathophysiologies of superior semicircular canal dehiscence. So thank you to all. If there are any queries, I would like to answer.
Thank you very much, Dr. Priti. Trainees, you may type your questions or comments in the chat box. Dear trainees, you may use chat box or the Q&A section to post your questions or comments.
So if there are no queries, do we end the session here then?
Just give a few moments, Dr. Preeti.
Okay. Sure, sure. Normally, when we are doing a Weber's test, we place it on the vertex or on the forehead. But here, in cases of superior semicircular canal, we were just trying to illustrate that even in bony prominences, because of bone conduction hyperacusis, even on bony prominences which are distant, there also, if we place the tuning fork, the patient would be able to hear the sound. Can you please show the initial? I hope the first query is being clarified. Can you please show the initial 3 to 4 slides? Okay.
Then we can do it later. We can move on to the third question.
Is there a third question? I do not see a third question.
The canal more decent than the rest of the semicircular canals.
Okay, so that is a very interesting question. So there is, it is not that I did search the literature for that. So actually, it is not, there is no clear answer to that. But one of the reasons which had been given in one of the papers was that probably the location of the dehiscence, superior canal dehiscence, is such that when the patient is erect, the weight of the brain, which is on the superior canal, is more than when it is, the situation, the location of the posterior canal dehiscence is such that the weight is not as much as in the case of superior canal dehiscence. So possibly that could be one cause. And another cause which I had mentioned in my talk also, that many a times these cases with posterior canal dehiscence are asymptomatic, and therefore that could be a reason for underreporting of posterior canal dehiscence cases.
Okay, ma'am. Thank you, ma'am.
Dr. Preeti, now you can share the slides.
Okay.
Share the screen.
Where is my presentation? Possibly here.
First, share the screen, Dr. Preeti.
Is that it? Yeah.
Excellent. We can see the screen.
So are these the slides that we are looking for? So this is discussing the anatomical aspects where we had described that the inner ear, the membranous labyrinth, is totally encased in a bony capsule except at these the oval and the round windows. But in addition to these bony mobile windows, there are some other openings in the bony otic capsule which are non-functional, like the cochlear and the vestibular aqueduct. They are non-functional, that is, they are not involved in transmission of sound energy because they are long and narrow and are high impedance pathways. So no sound energy can be transmitted through these pathways unless they are enlarged or there is a dehiscence in the bony capsule. Is this what you wish to see, or would I need to share more?
Dr. Nasiba?
Hello.
Yes.
Ma'am, just can you, I could not make notes of the remaining slide for 5 to 6 slides, ma'am. From
Okay.
posterior canal, I don't want explanation. I attended, ma'am, just to make notes. Can I?
Okay. So till when do you want me to show it? Re-show them?
Ma'am, just scroll it down till the posterior semicircular canal dehiscence.
Okay.
Okay, ma'am. Next, ma'am. Next. Next, ma'am. Next. Next, ma'am. Next. I think 2, 3 more slides.
No worries.
Okay. Next, ma'am. Next, ma'am. Next. Next, ma'am. Okay, ma'am. Next, ma'am. Next, ma'am. Next, ma'am. Thank you, ma'am. I think this is the last slide from the.
Okay.
Thank you so much, ma'am. It was a very nice presentation.
Thank you. Thank you. I'm glad you liked it.
Thank you.
Any other question or comment from any of the training? You may also use raise hand option. Dr. Teju, unmute and ask a question. Yeah, Dr. Teju.
The mechanism of ankle Weber, ma'am, like
Okay. So as I explained to you, there is basically these people are they have bone conduction hyperacusis. Could you understand the mechanism of increased bone conduction?
yes, ma'am.
So they have bone conduction hyperacusis, and because of bone conduction hyperacusis, even if the tuning fork is placed on a distant, normally the bony prominences that we place on is closer to the ear. Now, even if we place it on a distant bony prominence, that is the lateral malleolus of the ankle, the patient is able to hear it. And some have called it the ankle Weber. Does that satisfy your query?
Yes, ma'am.
Okay, thank you.
Thank you, ma'am. It was a nice presentation.
Thank you.
So I think no more questions. Dr. Priti, excellent presentation. Thank you very much for this presentation. And thank you very much, trainees, for joining us.
Thank you. Thank you very much to everybody. Thanks a lot.